Hello everyone. So today we are going to discuss approach to a case of HFpEF. So heart failure is not a single pathological diagnosis but a clinical syndrome consisting of the cardinal symptoms and signs, as you all know. This is due to a structural and or functional abnormality of the heart that results in elevated intracardiac pressures and or inadequate cardiac output at rest and or during exercise. So you know that the heart failure is now classified depending upon the EF, and now EF more than 50% is classified as HFpEF. And just wanted to note that there is another category which is known as heart failure with improved or recovered ejection fraction, in which patients of reduced ejection fraction, patients of EF less than 40%, when their EF improves of more than 10% by medical treatment or by other device treatment, and then when the EF becomes more than 50%, they cannot be classified as HFpEF, but they have to be classified as HFIMPF or recovered EF. So why preserved? Why not normal EF? Given the known variability of echo measurements, which is around inter-observer variability of echo is around 7%, and the controversies regarding the precise LVEF cutoff to define normal, the guideline decided to keep the EF of 50% as preserved. And also very high EF, like above 65-70%, which is also known as supranormal EF, is not normal. And when any patient has a supranormal EF, we should be hinting that there should be a search for any other pathology like cardiac amyloidosis, hypertrophic cardiomyopathy, infiltrative restrictive cardiomyopathies. So nowadays, if you see, there is a trend of decreasing patients of HFrEF and increasing in patients of HFpEF, which is now almost 50% of patients of heart failure are actually HFpEF. So why is this happening? Because aging of the population coupled with increased life expectancy thanks to the healthcare model. Now more number of patients are having access to healthcare. Also increased prevalence of cardiac and non-cardiac comorbidities, and also improved recognition of HFpEF in clinical practice, because the number of physicians and other medical personnel are now coming to recognize HFpEF. And there are other non-cardiac comorbidities which are more in patients of HFpEF life, like obesity, overweight, hypertension, COPD, diabetes, renal insufficiency, anemia, sleep apnea. Our patient also today has obesity, hypertension, diabetes. So all these non-cardiac comorbidities which are more in patients of HFpEF, they lead to chronic systemic inflammation, and which leads to inflammatory markers acting on coronary endothelial microvascular inflammation and ultimately leading to myocardial remodeling and dysfunction. So there are also some other cardiac comorbidities like atrial fibrillation, chronotropic incompetence, systolic dysfunction. Yes, there is systolic dysfunction in patients who have HFpEF. We will discuss that later. Atrial dysfunction, coronary microvascular dysfunction, pericardial restraint, and secondary pulmonary hypertension. So there are some theories of HFpEF. The first theory is primary metabolic, like patients of obesity and diabetes have increased epicardial fat, and how this epicardial fat causes HFpEF is that it releases more pro-inflammatory cytokines firstly, and secondly it can also act as a pericardial restraint leading to HFpEF. The second theory is about the renal theory, of which I would like to discuss because it is very interesting. Like in patients of HFrEF, if you remember, there is neurohormonal activation, and the angiotensin 2 and aldosterone, they cause sodium and water retention. But in patients of HFpEF, there is not much of neurohormonal activation, and the EGFR also in patients with HFpEF is actually normal. Then why the hell are we having sodium and water retention, fluid retention in patients of HFpEF? Like any patient of HFpEF, if he takes extra beer or pasta in his diet, he should just urinate it out. So why is he developing water retention? So the problem here is that sodium avidity is the problem. So either the proximal or the distal tubular increased propensity for sodium retention, or there is decreased propensity for sodium excretion at glomerular level. This is occurring chronically over decades. And sodium and fluid retention, which is occurring subclinically without any symptoms. And this subclinical congestion and stiffness leads to endovascular dysfunction. And then on top of it, whenever the patient has hypertension, LVH, diastolic dysfunction, then because of this decreased reserve, any degree of fluid retention and overload cannot be tolerated, and patient goes into HFpEF. The other theory is the HFpEF is a clinical syndrome theory, in which actually HFrEF is a disease which starts in the myocardium and it goes into the body. Like when a patient HFrEF decreased EF, the neurohormonal activation is there, and hemodynamic abnormalities then ensue, cellular abnormalities, CKD, that is goes into the body. But in HFpEF, the theory is that it is opposite, that it is starting in the body and then eventually it is affecting the heart. And the last theory, which is the more favored theory is the nitric oxide pathobiologically, which is going haywire, is the theory in which there is a metabolic milieu. There is obesity, hypertension, diabetes is causing oxidative stress, and nitric oxide signaling pathway is going haywire, is getting affected. And nitric oxide is present in endothelium all over the body, as you all know. And therefore, when nitric oxide is signaling is affected, the SGMP, CGMP is affected, leading to LVH, fibrosis, atrial dysfunction, and ultimately HFpEF. But the downside of this theory is that we had 4 big trials of nitric oxide, which were all negative. So still it is not very proven. So what do you see in the microscope of the patient with HFpEF? You will see inflammation, you will see hypertrophy, you will see fibrosis, and predominantly these patients of HFpEF are older. So always remember there are abnormal LA mechanics in patients with HFpEF. There is, because of LV diastolic dysfunction, there is LA fibrosis, there is atrial fibrillation, and there is atrial myopathy. And these patients, they become increasingly symptomatic when atrial fibrillation ensues, because you all know that the 15-20% the atrial kick to cardiac output is lost. So these patients become very, very symptomatic when the atrial kick is lost. So there are some other disorders which should be ruled out when you label a patient as HFpEF, like the cardiac causes of dyspnea that may mimic HFpEF. These are, I'll just enumerate them. There's a cardiac amyloidosis, HOCM, cardiac sarcoidosis, constrictive pericarditis, valvular heart disease, CAD, high output heart failures like liver disease, AV shunts, and thyrotoxicosis, myocarditis, toxins. So these disorders should be ruled out before you label a patient as HFpEF. Also ruled out ISD, lung diseases, masquerading as heart failure, anemia, hypertensive crisis, and pheochromocytoma. So how do you diagnose a patient of HFpEF? So initially the pre-test probability, that is clinical characteristics, should be there. And the diagnosis starts with symptoms and signs of heart failure with an EF of more than 50%. And there should be objective evidence of diastolic dysfunction, which I will tell you later. Please remember that you do not need elevated BNP in all patients of HFpEF. Almost 30% patients of HFpEF have a BNP of less than 100. So these are those patients of HFpEF with less intrinsic myocardial involvement. So all patients of HFpEF should have these 2 scores. The first score is HFpEF score, in which 2 points are given for BMI more than 30, 1 point for hypertension, 3 points for AF, 1 point for pulmonary hypertension, 1 point for age more than 60, and 1 point for LV filling pressure as measured on echo. And the score of 6 or more has a high probability of HFpEF. The another thing is the HFpEF algorithm should be followed in all patients of HFpEF, in which the first step pre-assessment is signs and symptoms of heart failure, comorbidities, ECG, echo, natriuretic peptide should be measured. The second step is diagnostic workup, in which echo and natriuretic peptide, if not measured, have to be measured. The third step is functional testing in case of uncertainty, in which diastolic stress test and invasive hemodynamic measurements can be done in patients, in selected patients in whom you have doubt. And the final step is etiological workup, like CT, MRI, PET. So any breathless patient, the clinical assessment has to be done like with Stagner diagnostic test, natriuretic peptides, ECG, X-ray, echo, and then the HFpEF score has to be calculated. I'll tell you how this score is calculated. And please remember, normal NT-PROBNP does not rule out HFpEF. So this is how the HFpEF score is calculated. Depending on the major and minor criteria, it is given the functional, morphological, and biomarkers. The NT-PROBNP is different for patient of sinus rhythm and AF. So functional is calculated on echo by tissue Dopplers, morphological on echo by LA volume index, LV mass index. And the major criteria given 2 points, and minor criteria is given 1 point. And if the patient has more than 5 points, then it is diagnostic of HFpEF. So this is how, if it is calculated, if it is low, this score is low, then you have to search for other causes. If it is high, then you have made a diagnosis of HFpEF. If you are intermediate, then you have to do a diastolic stress test, either invasive or non-invasive, which we'll discuss later. And if it is abnormal, then HFpEF is confirmed, and the final step is etiological diagnosis. Some patients, will require advanced HFpEF workup, that is stress echo. On stress echo, you have to measure advanced tissue Doppler parameters. And some patients may need invasive hemodynamic measurements like calculation of PCP-WP, which on rest, if it is more than 15, it is diagnosis of HFpEF. And on exercise, if your PCP-WP is more than 25, it is diagnosis of HFpEF. So final etiological workup is done in patients by a CT, MRI, PET scan in very selected patients to differentiate the initial causes which I told, just to differentiate that there are no other causes which are mixing up with patients of HFpEF. So this is how the integrated diagnostic workup should be done for all patients. Patients with unexplained dyspnea, you should calculate these two scores, HFpEF score and the HFpEF score, which I discussed. And if your patient has an intermediate probability, then only you have to move further to a hemodynamics exercise test, which I will tell you how. If you're high probability, then you have diagnosed the patient as HFpEF. If you're low probability, then probably you're dealing with something else. Now coming to an intermediate probability hemodynamic exercise test. So how is it done? This is a CPEX, that is cardiopulmonary exercise test, in which VO2 is measured, so that we can come to know about other conditions like impaired exercise capacity, or is it obesity induced limitation, or is it intrinsic pulmonary disease, or it is low stroke volume, or it is medication induced beta blocker versus chronotropic incompetence, or you can even prognosticate your patient of HFpEF on the basis of this VO2. So this is how PCPW is measured in cath lab. Invasive hemodynamic testing is done for patients with HFpEF, as patient with HFpEF often has large swings in intrathoracic pressure due to concomitant lung disease or morbid obesity, and therefore the end expiratory PCPWP should be measured. Some patients will also need dynamic measurement of PCPWP, like on feet up and on exercise, and in whom you cannot do this dynamic exercise, you can just give them saline bolus, 1 liter saline bolus, and measure their PCPWP. These patients are very sensitive to saline boluses, and therefore they go early into failure. And you can also think in clinical practice, whenever any patient is HFpEF is given a saline bolus, they go into failure. So phenotype guided approach to HFpEF, any patient or suspected HFpEF on invasive exercise hemodynamic, if your resting PCPWP is less than 15, and on peak exercise, if it is not increasing to more than 25, then HFpEF is ruled out. If it is increasing to more than 24 on exercise, then this is type 1 HFpEF, which is exercise induced LA pressure increase. And on resting, if your PCPWP is more than 15, and if any of these criteria are there, then this is type 3 HFpEF, which is pulmonary vascular disease or right heart failure. If it is not there, then this is type 2 HFpEF, which is volume overloaded. So what should be measured on echo in all patients of HFpEF? Your LV wall thickness, LV mass, LA volume, your LVEF by global longitudinal strain and not by your M mode, your tissue Dopplers, your E prime, your TR jet, your PAS should be measured. Also IVRT and tau should be measured. So IVRT is the time interval between aortic valve closure and mitral valve opening. It tells us about the early diastolic LV relaxation. It is affected by heart rate and arterial pressure. Whenever relaxation is prolonged, mitral valve opening is delayed, and hence IVRT is increased, and it is less than 70 normal subjects. So this is how it is measured. A cursor has to be kept between your mitral valve and your aortic valve annulus, and this is how we measure the IVRT. So what we measured, this is how it is translated invasively into the cath lab. This is what early diastolic relaxation we are measuring. So this is what we were discussing, that preserved EF does not mean preserved systolic function because of the arrangement of the myocardial fibers, you know, the circular, longitudinal, the different way crisscross arrangement. Every patient of HFpEF should have their global longitudinal strain measured, because there have been numerous papers which have been published that strain imaging can detect impaired systolic function despite normal global EF in HFpEF patient, which contributes to pathophysiology of the HFpEF. So how are the outcome of HFpEF different from HFrEF? In HFrEF patient, actually, the 75% of the cardiovascular causes, the death is because of 75% of the cardiovascular causes, most of which is sudden cardiac death and pump failure. Whereas in HFpEF patient, 50% of the deaths are because of non-cardiovascular causes. So that is why now you can imagine why drugs are having a very hard time in HFpEF to have mortality benefits. So the problem of heart failure in 2022 is not HFrEF but HFpEF, because these are the 50% patients of heart failure, in which 5 big trials have reported in last 15 years as negative. So where are we now in 2022? So we know till now that these 5 big trials have shown no benefit. So all over these were negative trials. And after the recent trials also, like your RAMP-PEF, RELAX, NEAT, HFpEF, EDIFY, Socrates, PRISM, all these were nitric oxide trials which are also negative. And out of these 7 trials, these 3 trials which we'll be discussing today is TOPCAT, Paragon, Emperor, Preserve, and the DELIVER trial. So these 4 had some beneficial effects in HFpEF patients. So first is the TOPCAT, in which spironolactone was given to patients with HFpEF. The primary endpoint was also not achieved in the HFpEF patient, but the spironolactone had beneficial effects on heart failure hospitalization. But the benefit of spironolactone diminished with increasing EF. So this was something which was not good. And diuretic use in HFpEF, it is said it is empirical use as in other patients also. If there is no need of diuretic, it is said that there is probably not heart failure. So another trial is Paragon HF. Just like the brother Paradigm HF in reduced, this is the Paragon is done in patient with preserved ejection fraction. 5,000 patient with EF more than 45% was given this ARNI. So in this also the primary endpoint was not achieved, but there was improvement in the NYHA functional class. And if you see the subgroup analysis of Paragon, the female patient achieved their primary endpoint and the patient with EF of 57%. So this magical number of 57% was achieved in this trial. That is means your patient of EF 57% or lower will achieve the primary endpoint, whereas more did not have a beneficial effect. So benefits were according to gender and EF marginally significant, if you can say. So depending on this, FDA expanded the RN indication to HFpEF, but this has not yet translated into the guidelines. So what do the guidelines at present tell us? So basically and practically nothing. The guideline is just telling us you treat your comorbidities, you treat your systolic diastolic blood pressure, use diuretics, treat your CAD according to GDMT, you manage your AF, you give beta blockers, AS, ARBs as a class 2A indication and ARB as a class 2B indication. So practically nothing much in the guidelines. So if you have understood the pathophysiology of HFpEF, which I told earlier, now you will understand that why SGLT2 inhibitor having a beneficial effect in the recent trial, because it is causing decreasing cardiac preload, ventricular remodeling, atrial remodeling, systolic dysfunction, diastolic abnormality, fibrosis, and increasing endothelial function, decreasing the vascular stiffness, decreasing systemic blood pressure, fluid overloads. So where are we going now? So these are the trials of SGLT2 which have been lined up to 2023, and out of which the Emperor Preserved trial results are out, and the Deliver trials results are going to be out next month. So coming to the Emperor Preserved trial, so the Emperor Reduced was in EF less than 40, and this is Emperor Preserved, which was done in EF more than 40%. So these patients were given empagliflozin 10 milligrams. So it achieved it. This was the first trial in HFpEF which achieved its primary endpoint. So 21% relative risk reduction was seen in the NNT-31 and statistically significant from day 18. So this was very exciting because the first trial in HFpEF which achieved its primary endpoint. And if you go to a subgroup analysis, there was no difference between diabetes, non-diabetes, no gender difference. But what was seen that if you go on increasing your EF from 50 to 60% in 3 groups, there was decremental benefit which was seen. So this is slightly disheartening, but this is what we have now. And if you consider subgroup analysis of patients with EF more than 50%, that is your predominant HFpEF patient in all of these trials, then this is where Emperor Preserve stand out. That is 70% reductive risk reduction as compared to the other trials of HFpEF. So this is what was seen. There was a discordance seen in the estimated eGFR and the renal outcomes in the patients which was seen in Emperor Preserve. That is, the initial notch was seen in the patients of this trial when the empagliflozin. This notch is seen in the AS and ARB also in all the patient, and after this there is an improvement in the eGFR at the rate of 1.36 ml per year. But this improvement was not translating into the renal outcome. That is, the patient was not having benefit in dialysis, renal transplantation. So this is just like atenolol in heart failure, that your pressure is getting decreased, but you are not having mortality benefit. Now why is there this discordance? This will be answered by the other trial like the Deliver trial and the other trials which are ongoing. But there was also seen positive improvement in NYHA class in the trial, and also first secondary endpoint, that is total heart failure hospitalization, were also decreased by empagliflozin in HFpEF. And not only patient who required ICU admission, who required IV vasopressors and IV inotropic agent had decreased hospitalization, but also patient who had come in OPD. The OPD visits also decreased in patients with HFpEF. And the beneficial effect was seen right from day 80. So you can see how beneficial was this drug in patients of HFpEF. And what were the adverse events? This was a pretty stable drug. There was not much of difference between the empagliflozin and the placebo. So it was a safe drug for HFpEF. So all the 3 endpoints were achieved in patients of HFpEF. That is primary endpoint, secondary endpoint, and secondary endpoint of eGFR were achieved. And if you consider the subgroup analysis of patients of more than 50% only, then also the primary endpoint, your recurrent heart failure hospitalization, your quality of life, your kidney function, all of these were achieved. So this is where we stand right now, the only trial with positive effects in the background of all these other negative trials. So the one drug, 2 trial for less than 40% and more than 40%, both of them positive. And this is the Deliver trial, which is ongoing, which has been just completed, but the results are going to come next month. So 6,000 patients of HFpEF were given dapagliflozin, and we'll see what the result comes next month. So one more trial was which was Preserved HF trial done in HFpEF patient, dapagliflozin improved the 6-minute walk test. And these are the pillars of HFpEF in 2022 patient. So the patients of HFpEF when discharged from the ICU should be on a SGLT2 inhibitor, on an ARNI, and on an aldosterone antagonist. and diuretic for symptomatic use. So any patient who is of HFpEF should have been these drugs, should be given these drugs to reduce the mortality benefit. So what are the future treatment in obese patient? Maybe GLP-1 receptor agonist, ketogenic diet, bariatric surgery. The future which is in pipeline is greater sampling for sphenic nerve ablation, Cameron antisense, oligonucleotide, some neprilysin inhibition, PDE9 inhibition, and many interatrial shunt devices are in pipeline, but all are in developmental stage because of the increased LA pressures. What is the surgical management of HFpEF? So we know there is increased LV filling pressure, but what to do about it? So you can slice up the pericardium so you can allow the heart to fill more easily, just like we do in constrictive pericarditis, and it can be done percutaneously for a very elderly patient, frail patient who are not suitable for any other surgeries. So you can a single slit in pericardium. It has been studied preclinically that there has been higher LV compliances by saline load. So all this is in pipeline, and we'll see. So HFpEF is a common underdiagnosed heterogenic systemic multi-organ reserved dysfunction syndrome. Diagnosis is challenging, but high degree of suspicion, and following guideline-directed algorithm, diagnosis can be made certainly. So the gold standard is the invasive diastolic stress testing, which I told you how to do the invasive testing. And the HFpEF score is useful in patients with unexplained dyspnea. Always exclude the mimickers. The treatment is currently directed to symptomatic and congestion and comorbidity treatment. ARNI is approved to reduce the cardiovascular risk and heart failure hospitalization. However, the benefits are most clearly evidenced in patients with EF below normal. Guidelines are presently being revised, and ARNI and SGLT2 will be the promising new additions. Thank you.